Good morning, everyone. I'm Shubhra Ghosh, Project Manager for Global Programs at the University of Texas MD Anderson Cancer Center. Welcome to the satellite session number 24 at the 2021 CUGH Annual Conference. Today's session is titled Building Capacity for Global Cancer Prevention, Diagnosis, and Treatment, and it is being presented by MD Anderson Cancer Network's Global Academic Program. While the need to advance cancer services is local in any community, the urgency to do so is global. So in the last 20 years, as the burden of cancer has shifted to the low and middle income countries, we at MD Anderson have reached out to engage with the stakeholders in the ministries of health, in the governments, and in non-governmental agencies, other leading cancer centers, as well as organizations worldwide to be able to join forces to fight against cancer. Our effort has mainly focused on three areas. Number one, to support the training and education of doctors, nurses, technicians, and to help build capacity for diagnosis, prevention, and treatment of cancer. And the second thing we are focused on is working with the governments to develop and implement policies for the cancer prevention and care, and supporting translational research so that these studies can be scaled up to clinical trials and eventually lead to approved treatments. It will be our effort to highlight each of these three areas throughout the course of this year's CUGH conference. However, today, in this session, we'll be presenting some of the ongoing collaborative programs at MD Anderson and McGovern Medical School for building capacity for research, laboratory diagnosis, prevention, and treatment of cancer in different contexts and in different geographies around the world. Our international collaborators from Mozambique and Zambia will be joining us for various topics, and we'll have a special focus on involvement of nurses and trainees in these activities. There will be a discussion after each set of presentations, and we look forward to your active participation. So with that, I'd like to turn this over to Melissa and Dr. Kathleen Schmaeler. Dr. Schmaeler is Professor of Gynecology, Oncology, and Reproductive Medicine at MD Anderson, and also a world-renowned leader in global oncology. So over to you, Dr. Schmaeler and Melissa.
Good morning, everyone. Thank you so much for joining our session, and thank you, Shubhra, for those opening remarks. We'll dive right into it since we have a lot of presentations today. We're super excited to have everyone here and to be part of the discussion. Melissa, would you show our, perfect.
Okay, thank you everybody again and welcome to our session, and I hope you all enjoy it. We have divided the session in three blocks. So our first block would be about collaborative programs for capacity building for clinical care and research. We have three amazing talks prepared for you about different programs building capacity in Mozambique, in Zambia, and to establish laboratory technologies, radiation therapies training programs. Dr. Kathleen Schmaeler will facilitate a discussion for that block, and then we'll move to block two, which will be a conversation about global oncology, nursing education, and cancer prevention programs, which will be facilitated by Dr. Ellen Baker. We'll have a break at 10:20 to 10:30, and then we'll finish with the last block for the day, which is the role of physician trainees in global oncology. And then we'll finish with a group discussion at 11:30 to 12 p.m. So we thank everybody again for being here. And we are going to start with our first discussion about cervical cancer prevention capacity building in Mozambique. So allow me please to go ahead and share my screen again. Okay, Ellen and others?
Not yet.
Okay, can you hear this?
Dear colleagues, it is with great pleasure and honor that I accept the invitation for providing this presentation about program collaboration between Mozambique, MD Anderson, and Brazil. I am Cisaltina Lorenzoni from Minister of Health of Mozambique and Hospital. I will do this presentation with my colleague Mila Contremole Salcedo from the University of Texas, MD Anderson Cancer Center, Houston, United States of America, and Santa Casa Hospital of Porto Alegre, Universidade Federal de Ciências de Saúde de Porto Alegre, Brasil. Building a strong local cadre of providing in cervical cancer prevention. This collaboration began in 2014 by invitation of the former First Lady of Mozambique, Her Excellency Dra. Maria da Luz Gebuza, and current First Lady, Excellency Dra. Isaura Nussi, and Minister of Health. In January 2016, we signed the Memorandum of Understanding between MD Anderson and Minister of Health, where the such areas were included: clinical, surgical training in cancer prevention and treatment, research and capacity building for cervical cancer prevention. We focus at the cervical cancer prevention because Mozambique has one of the highest cervical cancer rates in the world. As you can see in the picture, there is a nurse that is assisting the woman at a health facility unit from the maternal and child program. The nurse can perform a cervical examination and do the VIA and cryotherapy. About the capacity building, clinical and research, 13 visits since 2016 are done by the teams from MD Anderson and Brazilian colleagues in the breast, gynecology, head and neck, hematologic cancer areas. Hands-on training are done also in surgical and medical oncology. Technical course was performed and also colposcopy and lip course. About research collaborative projects are going well, such as collaborative studies with the Ministério da Saúde, Universidade Eduardo Mondlane, Maputo Central Hospital, Mavalane General Hospital, PSI, SHI, and these studies are supported from Anadarko, PCFI, USAID, and US government.
It's an honor for us to be part of this collaboration. And regarding the colposcopy and lip courses, since 2016, we have delivered 12 workshops. They were attended by 170 different individuals from around the country, and some participants attended multiple times in all of our courses. The training includes supervised patient care, and we do monthly video conference in Portuguese. We use the module as Project ECHO, and these video conferences, they were attended by around 60 or 70 doctors each month, doctors and nurses for each session. Our plans for 2021 is to provide a blended courses, virtual and in-person training courses. Because of the COVID-19 pandemic, we needed to adapt. So now we are starting doing these blended courses, some virtual, some in person. It depends on the country in Mozambique and their organizations. We lead monthly Project ECHO conference with nurses, with doctors, and these are supported, and we provide technical support for these video conference with the doctors and nurses from Mozambique, and also our colleagues from Brazil that are helping in all this conference. We provide also technical support as needed for the Minister of Health in Mozambique, and we provide mentoring for supervising master trainers and regional trainers in Mozambique as well by video conference during 2021. This is one of our courses around the country. we spent some time in other provinces, not only in the capital, and this was, of course, in Nampula with our whole team from MD Anderson, from Brazil, from the Ministry of Health in Mozambique, our partners from Mozambique, and all the attendees from the course in Nampula. And this is the IGCS Fellowship Program. This is a gynecologic oncology training and education program. IGCS is the International Gynecology Cancer Society. It's a web-based curriculum, 2 years curriculum, and this is a partnership between the Hospital Central de Maputo, the Ministry of Health of Mozambique, our international faculty. We have 5 doctors from Brazil, from different institutions in Brazil, and we have 1 international mentor here from MD Anderson. The international faculty travel to Mozambique 5 or 4 times per year to train the fellows and to help them in the clinical settings, in the surgeries, and also in pre-invasive disease. And Mozambique was one of the pilot sites for this fellowship program in Mozambique. The fellows also spent 1 to 2 months in Brazil in some of the international mentors institutions. And we also have national mentors there in Mozambique to help the fellows as well. And we had the pleasure to say that our 3 first fellows from Mozambique, they graduated in October, and now they are the leaders in the country, and they are reference gynecology oncologists in the country. And this whole program, of course, is from IGCS, supported by all the institutions, the 5 institutions from Brazil, and MD Anderson and the Ministry of Health in Mozambique as well. So as I said, it's a comprehensive 2-year education and training program in gynecologic oncology for countries that they don't have formal gynecologic oncology training, and it started in 2017 in Mozambique. 3 gynecologists were paired with 5 specialists from Brazil and 1 specialist from the US. It's an established curriculum. We had regular visits even for clinical or surgical trainings. And we had 27 monthly virtual tumor boards with them using Project ECHO. And in these tumor boards, they presented cases from Mozambique, and the international and the national mentors, they all worked together to help the fellows to solve all the cases. We have a lot of surgical cases logged with the mentors and without the mentors. Now they are doing independently from the mentors, the 3 fellows or graduated now doctors together, and they did observership in Brazil, as we said before. So we are very, very proud of Dercia, Ricardina, and Ciro, our 3 fellows that graduate from Mozambique, and we have our 6 international mentors, Marcelo, Renato, Georgia, Kathleen, and myself, and Andrea Lopez. And the local mentors are Dra. Elvira and Dra. Magda, and Dra. Cesaltina always help us as well. So this is a picture in a surgery in Mozambique with our fellows. And we also do building capacity. We also build capacity in research in Mozambique. And this was the first collaboration research in between Mozambique, Brazil, and the US, the Capulani study. It was done at Mavalani, and we screened 898 women. The HPV rates was 23%, and the HIV rate in the study around 20%. More than 90% of HPV positive women completed all the steps for their diagnostic, workup, and treatment. So what proves that it's possible, what WHO is asking us to provide the 90% treatment of all these patients. And we have a new study going on. It's an evaluation innovative technologies and approach to addressing cervical cancer there in Mozambique, in 2 provinces, Maputo and Gaza. And again, the women will be, they have been screened with HPV, self-collection and provider collection. And we have been treating the patients with ablation when it's possible, with thermoablation, cryotherapy, or LEAP, or the patients have been sent to the gynecology oncologist for cancer treatment. And with this study, we will also develop new technologies with our partners from Rice University. They are led by Dr. Rebecca Richards-Gordon. And the MD Anderson team is led by Dr. Kathleen Schmaeler, that is here with us in the picture. And these are all our collaborators. We are very happy and glad that we have all the collaborators around the world, so from Brazil, from Mozambique, and here from the US, and also our sponsors. So thank you so much. For our team, the education and training and capacity building are key. So Cesaltina, Kathleen, and myself, we thank you for your attention, and we are happy to address any questions. Thank you.
Great. Thank you so much, Mila and Cesaltina. As we said, we'll hold questions until the end of the session. Our next talks will be from Dr. Susan Sitonji, as well from Zambia, as well as Dr. Anuja Jingran from MD Anderson, and they'll discuss radiation therapy training, the radiation therapy training program that they have developed in Zambia.
So as you know, in Africa, we see close to 1 million new cases of
I'm afraid we may have just lost Susan.
Correct. I don't see her anymore as a...
Oh, here she comes again. Anuja, do you also have the slides?
Can you see the slides?
We can see the slides, but it's in that split mode. If you can put it, I don't know if you're on two screens, in full presentation mode, and it's also not on the, it's on the 6th slide, not on the first one.
Okay.
We can go back to the beginning.
Yes. Are we okay now?
Yeah, it's just not the first slide. There we go.
All right. So let me, I'm sorry, I'm going to have to do this for Susan, so I do apologize. In Africa, just to start off, so there's over 800,000 new cases and 500,000 deaths per year. As you can see, the number one cancer is breast cancer, but cervical cancers 14%, prostate, colorectal, and liver cancers fall the next. HPV is probably the highest responsible for cancer, but hepatitis, HIV are also very responsible for cancers. I mean, HIV is responsible for 26% of the cancers in Africa. So 11% of the world population is in sub-Saharan Africa, 25% of the global burden of disease is in Africa. 3%, though, of the world's health workers are in Africa. Less than 1% of the global health money is spent in Africa. So we're going to talk about Zambia, and again, this is all of Susan, so I need you guys to know that this is all Susan. So we'll talk about Zambia, which has a population of 17 million people. Cancer deaths are 7,000, and cancer cases are 24,000. And just, I'm sorry, I'm going to go back. And briefly, the number one breast cancer still is breast, but also cervix. Cervix is the number one cancer at 24%. Then we have other cancers, and breast falls at 7.4%. So this is a great slide, and I really think this is such a relevant slide that Susan's put up here. When we first went to Zambia, this is what we saw in 2007. It was a small outpatient hospital that had only radiation therapy and chemotherapy. They depended on all their labs as outpatients. There was only 4 oncologists, 4 radiation therapists. So this is really what we saw when we first went in 2007, but this is what at Zambia is now, which is just so impressive. They have an independent lab and radiology service. They have nuclear medicines. They have inpatient hospital. There are 7 oncologists, clinical oncologists, and 24 radiation therapists, 4 MPs, and they're treating over 4,000 patients. So I mean, the way where they come from 2007 to now is just totally impressive. So the plan is for decentralization. I mean, right now the number of clinical oncologists is inadequate for the current burden or the expansion of services. There was no local training program, and attempts to get local universities to take up a clinical oncology program was futile. The training to do it abroad was cost prohibitive, and so there was an evidence to establish long training programs in the country. There was, as you can see, there was a large number of new cases in Lusaka and really no access to treatments. So what they decided to do was look at what was the need. So the needs were 120 clinical oncologists by 2030, which is huge. And according to the estimated number of cancer incidents by 2030, the IAEA recommends 1 clinical oncologist per 250 new patients per year. So the target was to do 40 specialist clinical oncologists in 10 years. So CDH had the resources. They've had a previous training program in radiation therapy. They had the human resources. They had teaching staff. They had the infrastructure, and they had the patient numbers and cancer centers. As you can see, this is a conference area that they have. This is the hospital, and now they have this inpatient hospital. So how did MD Anderson come in? Well, we came in to help with the teaching resources. So we've developed ECHO teleconferences. We did didactic programs, both in-person lectures, cancer sites, physics and radiobiology, and clinical research that we just started. And the sponsors were GAP, ECHO, MD Anderson Radiation Oncology Division. So the progress. The first intake, we're already actually in the 4th intake in 2021. They've received international trainees from Botswana, from Malawi. So you can see there's multiple different areas that they're receiving trainees from. So the key thing was it started in 2017. So they started in 2017, and you can see how much progress that they have made since 2017. They started identifying the working group, they started enrollment, and the program began. And so, like I said, we are in the 4th year in 2021. So, and we started in 2018. So not we, Susan started in 20, and they've made a huge progress. And so what Susan would like to do is thank a lot of people who helped address the critical gaps in human resources, including the Zambia faculty, MD Anderson faculty, the patients who allowed them to learn on them, the government of Republic of Zambia, International Atomic Energy, and the Brighton team from England. And so I think this is Susan's ending, education is the most powerful weapon, which can be used to change the world. And Susan wants to thank everybody for listening. And I just want to just talk a little bit about what we did in Zambia. So I'm going to start off, and this is actually just show you the results of what a small course can do and how much it can make a difference. So this is an in-person course that we did in Zambia, radiobiology and physics. And actually, this is a paper that we've actually published, and we actually did a survey of the Aortic Training Interest Group members, 17 institutions in 13 countries throughout Africa. And we first looked at, who filled out the survey. And you can see 36 people filled out the survey. Majority of them were clinical oncologists. We asked them what radiation therapy services were offered in their institutions. And you can see majority of them had brachytherapy, had Linacs, or Cobalt. The utility, the type of radiation they delivered was 3D conformal or 2D, but some did do IMRT or VMAT, and some did SRS. So we asked them, who do they train and what do they train? So majority of them do train clinical oncologists. Few of them did train medical physicists. Dosimetry was very rare, and majority of them, though, also did train radiation therapy. So the next question we asked was, is formal instruction important in radiobiology and physics? And all thought that formal instruction was important. Majority of them did provide formal instructions in radiation physics, but about 70% did in radiobiology. Most of them did have instructors employed that could instruct in the subject in radiation physics, but as you can see in radiobiology, only 50% of them had people that available to instruct in radiobiology. And you can see the current level, they felt that radiobiology was not adequate presently, and about 60% felt that radiation physics was adequate. So what we asked, what were the major challenges in trying to provide this education? As you can see, the major challenge really was experts in treating and teaching radiobiology and radiation physics. So we did an in-country radiobiology and radiation physics course in Zambia. We had both clinical oncologists and radiation therapist students come. And this is actually the pre-test, and you can see the clinical oncologist did have some idea about radiation biology up front, where the radiation therapist had some knowledge of both biology and physics up front. The scores were correlated with what their pre-test scores were correlated with what they knew up front. This is the post-test, so pre-test and post-test. As you can see, the knowledge in both radiobiology and physics increased after the course, and this was a week course in radiobiology and a week course in radiation physics. And you can see that both the scores improved as well as their knowledge, and you can see that their knowledge improved significantly. So even a week's course in radiobiology and physics made a significant impact in the training of these clinical oncologists as well as radiation therapists. So in conclusion, there is a severe shortage of oncologists and therapist personnel throughout Africa and has impeded treatment of cancer patients throughout Africa. To address this shortage, training programs are so important, like the program that has been developed in CDH, and they've done, as you can see, such an amazing job. But it's really important that the training programs include radiobiology and physics. And as you can see, even a short course of 1 week in physics and biology improves the confidence level and the knowledge of both clinical oncologists and therapists, and makes them feel better prepared to take care of their patients. And so I want to end this talk, and I really appreciate you listening. And I'm so sorry that Susan could not give her talk, because she would have done a much better job than me. But if there's any questions, I really appreciate people asking at the end, and hopefully Susan can join us at that time. So thank you for listening.
Great, thank you very much, Dr. Gingran. And again, we'll hold the questions until after the next talk. Please, for all the audience, feel free to put any questions you have in the chat, and we'll address them during the session discussion. Our next series of talks are going to be on the topic of establishing laboratory technologists, radiation therapist training programs. And we would like to welcome Dr. Peter Hu, Mark Bailey, and Sean Caldwell. Thank you. And also just a note that all the bios are available in the information that was sent to you, as well as on the website.
Good afternoon, depending on where you are at today's conference. So my presentation for the next few minutes is on what you need to establish allied health programs. The next few slides, I've designed it to serve as a template for you to use, and hopefully you can use this template to fill in the gaps with the information to present the program to either your administration or to any other officials to get the programs approved. One of the things that, one of the mistakes that a lot of people make is when they present their proposals, they don't have the right type of information, and it leaves a lot of rooms for questions and doubts. So hopefully these slides will help you remove some of those pitfalls. So the first thing you want to do is you have to do what is called a needs analysis. And this is usually a combination of both the market needs, and you can get the information from that through a basic literature search. Either find out if the current profession exists or if it doesn't exist. And then if so, that would take you to the next steps you need to do. If the profession exists, then what you need to do next is you need to survey the stakeholders. Usually the survey question will include questions such as if you do create a program, would the employers be interested in these professions? You have to survey the students. If you create this program, would the students be interested in attending? And so these two pieces of information are critical because it will help you decide whether or not if this is a worthwhile investment to move to the next step. So this would take about half of the work in the beginning. Now, if it is a positive response from both the literature search and also from your needs surveys, then the next step is you need to establish a curriculum. You have to decide at that time what type of a curriculum is it going to be. Is it going to be in a traditional program or accelerated program? If it's a degree program or non-degree program, you have to then think about the number of credit hours, the actual curriculum, how it is separated out between semesters, how many semesters, and then the level of the program you want to offer, whether it be a certificate training or if it's undergraduate, post-undergraduate, or graduate. All these have to be put together and thoughtfully planned out. And of course, with these days, with all the different types of delivery formats, is the program going to be an online program, a hybrid program, a face-to-face? Once you have these pieces put together, you're one step closer to the next part, which is the resources. Now with the resources, of course, you start off with the basics. Does it require labs, existing labs, or you need new labs? And what type of labs? Is it dry labs or wet labs? If it's computer-based type of programs, for example, if you want to start in a molecular diagnostic program, nowadays you would also have to include bioinformatics, biostatistics. Do you have a computer lab to go along with that? Classrooms, and of course, when it comes to supplies, you need equipment, starting equipment or existing equipment, lab supplies, and of course you need FTEs to teach the students. It'd be full-time employees, part-time employees, adjunct, or contracted employees. And so once you have these tables put together, usually what the administration wants to see is a model projection, projecting out to 5 years. So year 1, year 2, year 3, year 4, year 5. These days, when all the programs in administration are moving towards more of a metrics-based, they would like to see a reverse type of cost, meaning that the cost, the initial cost is minimal, and then the cost gradually picks up. However, it is offset by the revenue that you will be bringing in, which that we will talk about in the last slide. So there is a reverse projection rather than more of a prescriptive way in the past, where they require a large amount of seed money, and then over time they'll recuperate that through revenue generation. And so once you have these three pieces put together, the last part is, of course, the financial pro forma. What is the funding source? Are you asking, how much are you asking? Again, They want to see a projection model out to 5 years. Typically, a sound program would have minimal costs in the beginning, and it would have a better return over time. In terms of if you're asking for money from the institution, or do you have a philanthropic source, do you have grants, if it's a university or degree type of programs, are you going to charge tuition? And so those pieces of information is important when you put this application together. And of course, if there's any other type of additional funding that you can get either from local, state, or federal, all these information when put together, along with the other three pieces, then it becomes a more a well-balanced application that you can put forward. So that's it for my presentation. Hopefully you can use these 4 slides as templates and fill in the gaps in between as you gather the information and have a successful submission. Thank you, or good afternoon, depending on where you are.
Thank you, Dr. Hu. Melissa, do you have the video, the next video?
Hello, so I'm going to be speaking about creating and directing a sustainable histotechnology training program in the global community, in the global health community. And what my talk is based on is the experience that I was able to acquire in Lusaka, Zambia at the Cancer Disease Center there. So let me go to the next slide. So when you're getting started with thinking about starting a training program in a hospital, either in Africa or some other continent or country, these are the 3 main areas that you have to think about. One, you need to do an initial site visit to look at the qualifications of the histology personnel. You need to ask who's going to be the trainer and who will be the trainees and the students. And then the most important thing is funding sustainability. And in my take-home message, I'll talk more about that. So those are 3 things. Then you have to begin to plan. What are the limited resources for the, what's the time and resources that the hospital has where you're thinking about doing the training. The logistics is very important. Is there ability to ship supplies and instruction materials to the hospital with very little interaction with customs? Then you have to think about the hospital's laboratory itself. Do they have a consistent utilities such as electricity and water and also internet connection as well? And then you want to find out who will be the coordinator between the liaison coordinator between the sponsoring institution, such as if MD Anderson was going to sponsor the training, and the liaison in the country where you're going to do the training. So the challenges are the in-country supplier. So this is one thing that we experienced in Zambia. Yeah, we wanted them to purchase the reagents in their country, but there's no suppliers. So then you have to think about what are the restrictions. Do they have foreign currency limitations? Do they even have distributors in their country that service their country? So that's one of the things you have to overcome. Then you want to look at the overall operation of the lab there. One of the first things that we had to do in Zambia was look at how we could improve specimen collection and fixation of the tissue. Also, the histotechnology lab supplies. What about the reagents? Where are they getting them from currently? Where are they getting the supporting ancillary reagents for the histology tests that you have to do on the tissues? What about their blades, the paraffin, the formaldehyde, the alcohol? Where is this all coming from? So this has an impact on the quality of the histology outcomes and also the training. And then finally, look at the way that they archive their specimens, because in most cases, when the pathologists are reviewing cases, they have to retrieve archived tissue in a very quick manner so that they can order more tests to compare to the patient's tests that are currently being conducted. So I spoke about tissue specimen collection. You can see kind of a before and after situation that occurred in Africa, in Zambia, so in Lusaka. So on our first assessment, the picture where it says, where you see the shelves with the specimens, they were very disorganized. We didn't know if there was enough fixative on the specimens. And we made some recommendations, and we were able to help them organize their specimen collection and their fixation. In the second picture, you can see this was a subsequent visit when we came back the second and third times. So you can see the improvement there. What about the fixation? In Lusaka, they were using formol saline versus 10% neutral buffer formalin. And if, I know there's not time to go over now, but if you look at the comparison of formol saline compared to neutral buffered fixed tissue, you can see a vast difference between the quality of the pictures, the color detail and the detail of the tissue architecture. And then one of the things that we run into, not only in Zambia, but also I ran into this in Ghana and Ethiopia as well, was that they want the hospitals in those countries wanted to order these very expensive, complex, expensive to run robotic instruments. And so in Zambia, what I did, instead of recommending them and recommending what instruments for them to provide, I recommended that we taught them and also that they used manual histology techniques, especially immunohistochemistry manual setup, because of the fact that when you're looking at a robotic automated IHC instrument, you have to run at least anywhere from 25 to 100 slides a day for the machine to work properly and also to justify the expense. So in Lusaka, Zambia, they were doing maybe about 10 slides a day for immunohistochemistry. So I developed this IHC manual protocol for them to use, and it really worked out very well for them when you're training the students and also the pathology staff there as well. So recommending manual histology training is the best way to go, especially in a low resource, low specimen count per day. And then here's the difference between disorganized tissue archival and then organized tissue archival. The one on the left, of course, where their bucket, they're sorting through the tissue blocks to retrieve to do more tests on. It takes them all day to find the specimens, whereas if you organize the slides in the tissue blocks on the right, which we did in the subsequent visits to Lusaka, it made life for the technologists and the pathologists much easier when they could go and find these specimens very quickly. My final slide is sustainability for training techs in other countries. And that is that you want to set up a monthly pathology teletraining session. And at these teletraining sessions, you would want to invite pathologists, residents, histology personnel. You would have two types of speakers, a board certified pathologist who could speak with the pathologist and review review slides and cases. And then you have a technical talk for the histology personnel who are actually doing the actual histology testing. So that is very doable to have these monthly or even bi-monthly pathology teletraining sessions. And I strongly recommend it in conjunction with the face-to-face training that you would do in country. But one of the final take-home messages that I wanted to give you guys is that it's very important that you have a very solid funding base. You need a benefactor. And I can think of two examples that have done very well with their with the people that they provide funding to in Africa, and that is Brigham and Women's Hospital and also the Fred Hutchinson Cancer Center in Washington. Both of these folks have put a lot of money and time and effort in providing a solid funding base so that they can provide training and also exchange programs where the techs from their hospital go to Africa, and then techs from Africa go to Brigham and Women's. for training. So it's a very important factor to have, is to have a very strong funding to really make the training in any other country possible outside of the United States. So that's all I have for you today. And I know there's going to be a question and answer session later on, and I look forward to meeting you and speaking with you then. Thank you very much.
Thank you so much, Mark, for that talk. We'll next hear from Sean Caldwell about radiation therapy.
Allowing me to speak to you today. The purpose of this presentation is to discuss the need for radiation therapists on a global scale and to identify how MD Anderson can help countries develop a self-sustaining radiation therapy educational program. By the year 2035, more than 25 million people will be affected by cancer, and 65 to 70% of the cases will occur in low and middle income countries where the lack of radiation therapy treatments are a major problem. 85% of the world's population lives in developing countries. These countries only possess 25% of the world's radiation facilities. On the other hand, 75% of the worldwide radiation facilities are located in developed countries for treating only 15% of the world's population. The percentage of cancer cases in developing countries versus all countries is expected to increase from 56% to 70% or more by the year 2030. Almost all cancer patients in developing countries lack access to effective cancer treatment, particularly to radiation therapy. Based on requests, the MD Anderson Radiation Therapy Program faculty have developed mechanisms to assist in developing educational programs in radiation therapy, to include consulting in the curriculum design of a baccalaureate degree program, developing policies and procedures for such programs, and assessing existing programs for quality improvement. We also can provide observerships for practicing radiation therapists or senior students at MD Anderson Cancer Center in Houston, Texas. Or we can provide a direct delivery of educational components adapted to the country's practices using web-based synchronous and asynchronous instruction with or without student travel to the United States.
Sorry, everyone, I think my internet is a little bit unstable, so my apologies. Can you hear me okay?
Yes.
Okay.
Yes.
Okay, sorry about that. So we have about 7 minutes. Melissa, I don't know if I missed the end of the talk or if it got cut off. There we go. I don't think we're able to hear the video. I don't know, Sean, if you want to do it live, just to finish the end part of it. It looks like Melissa's lost her internet connection.
I can certainly attempt
That would be great. Thank you.
Basically, my presentation included some of the work that we have done for the radiation oncology centers in Ethiopia. We've helped consult with their educational delivery system and content. We've reviewed content. We actually have worked collaboratively with Black Lion and the other hospitals in Ethiopia. We received a $6,000 grant of educational materials from our American Society of Radiologic Technologists, who have provided those educational components to Ethiopia for free. And we actually have received a grant, more a philanthropic donation for a faculty member and an expert level radiation therapist to go multiple times to Ethiopia to help assess and work side by side with radiation therapists, specifically as they are getting their linear accelerators up and running, and providing guest lectures, anything that they need to help. So we're very blessed by the ASRT and the ARD Foundation. The other thing that we've done is we have developed a full competency-based observership that the Ghanaian radiation therapists have asked for. Unfortunately, because of COVID, all of the work that we have done has come to a complete stop because of travel. And we're having difficulty finding funding to get the Ghanaian radiation therapists to Houston. But there's a variety of things that the radiation therapy program and the faculty have to offer to countries in need. And if anyone listening is interested in those opportunities, please contact me directly. I would love to have an individual conversation to help wherever we can. That's basically the whole intent of my presentation.
Great. Thank you so much, Sean. And thank you also for jumping in to do it live at the end. Our apologies for
Just want to say, if there's technical difficulties, of course, it would happen on me.
Well, thank you. Thank you very much. We have a couple of minutes for some questions before we move to the next session. One of the questions in the chat is from Dr. Ayrton Stein from Brazil. And his question is, he would like to learn if during the training in Mozambique, did we include clinical governance in order to improve cervical cancer surveillance? So Mila, can you take that one?
Yes, sure. I'm happy to. Thank you for the question. This was a great question. Regarding the governance programs, Mozambique is starting now to build their cervical pre-invasive disease guidelines with our technical support and the Minister of Health, and we always follow the WHO guidelines. There's a working group now at the Minister of Health working on it, and now they are also developing the training manuals with our technical support. We always, as I said, we always follow and help them following the WHO guidelines. And even in the courses or in the trainings, and when we are mentoring them as well. Dr. Cesaltina also invited the WHO staff to speak in some of our webinars, and they came, but it was great. And Dr. Ellen Baker, Dr. Cesaltina Lorenzoni, and some of our colleagues from Brazil, they worked together in the cancer control plan for the country a couple of years ago, and it was launched 2 years ago. And the training support also includes supervision and monitoring of clinical services. So we go with them, not now because of COVID, but we usually go with them to the clinic settings, and we see patients with them, and with all the support from the Minister of Health from Mozambique. And for the sustainability of our programs and continue education for our partners there in Mozambique, we also use Project ECHO telementoring program to discuss the cases from Mozambique, the local cases in the tumor boards. We hold this in Portuguese. We do for pre-invasive disease, and we do for cervical cancer treatment as well. They are monthly, but we also are very close. We are always in touch with our partners there, and the doctors and the nurses from Mozambique. So we together address the quality control between the teams, and to train them in the WHO guidelines, and to continue updating them as much as we can. And we are always in close contact, the team from Mozambique, the team from Brazil, and the team from here, MDN. So thank you so much for your question. It was great. And I'm happy to take more questions if any other one.
And just a comment on the question and on the response, it really highlights the need to, as an academic center like we are, to work very closely with the Ministry of Health. And we've been very fortunate that Cecilina wears two hats, both in her position in charge of cancer for the Ministry of Health, but also as a pathologist. And many of the issues that Mark and others brought up of really working together, both with the ministry as well as with the hospitals and academic centers. I don't see any other. A question from Dr. Kizu from MD Anderson, and she's asking, for the radiation therapy training in Zambia, is there continuing technical assistance or a way to solicit expert advice about more complex cases? I don't know, Susan, if you're able to answer that, or Anuja.
Yeah, so we do echo sessions once a week, which granted, since I took over Susan's talk, we do echo sessions once a week that are disease specific, and so actually the disease experts actually do those talks, and they actually do case presentations after that. So they are presenting complex cases at that time. They do have contacts, and actually it's a good question, and we probably do need to develop a better way of letting them present more of their complex cases and to connect with them. So yes, we will definitely work on it. But right now, we are doing case presentations, at least with each lecture, and they do present some of their complex cases. But I think that needs to be added a little bit more. I agree with you there. Maybe a tumor board or something, which I think would be a great idea.
Thank you, Anuja. Susan, anything else to add?
I think Anuja has said it all, that we do present our complex cases at the weekly didactics. So we choose the ones that we think we might need technical help with. But obviously more interaction, more case presentations, tumor board, as Anuja said, would be quite helpful as well.
Yeah, I think, Susan, you and I need to talk about that, because I think that's a great way to go. So what a brilliant question.
Great. Thank you all. It's 10:02 Houston time, so we're going to move on to the next session. This is block 2, conversations about global oncology, nursing education, and cancer prevention programs. We are very fortunate to have 2 of our nursing colleagues joining us from MD Anderson, Stella Dyke, as well as Kathy Dowdy, and Dr. Ellen Baker will be facilitating the conversation. So over to you.
Okay, thank you, Kathleen, and thank you everybody for attending. I'll just say a few words of introduction. And of course, we know that around the world, nursing plays a critical role in health promotion, disease prevention, and general well-being. And nurses are often the backbone of the healthcare system and frequently the only providers that a patient may see. And it's a great responsibility. Nurses are a very scarce resource, and the WHO estimates that in 2030, we will need 9 million more nurses globally. Nurses are not evenly distributed around the globe, and in many countries, the number of nurses per capita is only 10 or 20% what the WHO recommends. Opportunity and availability of subspecialty training in nursing is not available in many places, though the need for nurses with specialty training is very great. In the last several years, there's been a growing focus on cancer prevention and cancer treatment, and the scarcity of specialty trained oncologists and nurses creates an additional challenge to delivering services and providing high quality care. In addition, with very few physicians with specialty training in oncology, additional responsibilities have often been shifted to the nursing workforce. So we're very lucky today to have 2 of our nurses from MD Anderson who work with colleagues in sub-Saharan Africa to provide support and guidance and education in oncology nursing. So Kathy and Stella, thank you so much for joining us today. And I guess I would just like to start with a very brief introduction. If you could each tell us maybe 1 or 2 minutes about your your work in global oncology nursing education. Maybe start with you, Stella. You're muted, Stella.
Thank you so much, Dr. Baker. My name is Stella. I work in the gynecology department, inpatient, before I became an educator. So since 2006, I have been doing medical mission to Nigeria. And as Dr. Baker said, the role of nurses are backbone of healthcare delivery, and the role of oncology nurses is very significant in cancer prevention in both low and middle income countries. So my work started in 2006, and it involves education of healthcare providers, education of nurses in some of the institutions that we went to, and also community health education. So we dealt with mothers, teaching them about breast cancer and cervical cancer. And most of these work initially started through NGO, non-governmental organizations. It is very significant for nurses to participate in global oncology health, and whether in high income countries, such as
You muted yourself again, Stella.
Sorry. Involving nurses are very significant. As you know, physicians can do
Stella, you're muted again.
I'm sorry, I'm not touching it. I don't know what is going on. I'm so sorry about that. But anyway, yes. So even now that we have, COVID, it will not stop, nursing education and reaching out to low and middle income countries. So through our ECHO project, like the Cameroon ECHO and also palliative ECHO, we're still able to log in and be able to answer some of the questions that nurses may have from other countries. So I will stop here and see if Patty, my colleague, have something to add to that. Thank you.
Thank you, Stella. And Kathy?
Hi. So I'm a women's health nurse practitioner. I've been one for about 28 years and a nurse for over 40 years. And I've been working in global health for a little over 10 years since Dr. Schmaeler contacted me one weekend and asked me if I wanted to go to Nicaragua. And I said, when are we leaving? And so we went and worked. At that time, I worked with the nurses in Nicaragua, helping with teaching about side effects of chemotherapy, putting together a program that was in Spanish, teach patient education teaching for the patients there. You had one nurse caring for about 12 people getting chemotherapy at one time with literally no assessment or patient education. So that's where it all started. And been lucky to go to Guatemala and do VIA with Dr. Schmaeler's group, and now to Mozambique a couple times. And of course, working with Project ECHO, was able to get my doctorate working with the project there, and being so interested in helping any way I can around the world. So most recently, my role has been hands-on training, mostly for colposcopy, biopsy, and lead training. We've been South and East Texas, where a lot of people don't realize we actually have quite high rates of cervical cancer here in Texas due to lack of insurance and access to care, but also going to Africa twice, which was a wonderful opportunity to meet some fabulous people and really learn a lot about what needs people have around the world. So I'm just kind of a part of the team, available to help any way that I can with the skill set I have. And so that's me.
Thank you, Kathy. I wonder now if you might each say a few words about how you first got involved in nursing education outside the borders of the US, and what advice you might have for other nurses who are interested in pursuing this type of work. And Kathy, we can start with you on this one.
Okay, so as far as nursing education, I think as nurses, we are teachers anyway. We always mentor each other, help each other, teach each other. So this comes as like second nature to us. And we, if we go into a region that we're not familiar with, it's really our job to observe, see what the needs are, and then try to teach or help according to the needs of that region, not to go with a preconceived notion of I'm going to do this or that. You have to listen to the people there. So Stella is an actual educator, professional educator at MD Anderson. So she may be able to put that more eloquently than I can, but I'm really basically a resource that's available on any level. I at MD Anderson do presentations in the institution as often as I can, just to teach people what's out there as far as nursing and nurse practitioners and the needs of, globally for us to help. I'm always trying to tout the wonderful things about nurses. We can help with education, prevention, treatment, surveillance, policies, research. Nurses can wear many hats. So a lot of people just aren't aware of all the many wonderful things nurses can do. So, and nurses are part of that group. We have to remind them as well and empower them to use all of their skills to help. So it's I don't know if that answered your question, but it's kind of me.
Yeah, thank you, Kathy. Stella, did you have anything additional to add?
Yes. So I encourage nurses to participate in global health as much as they can. Actually, the International Society of Nurses in Cancer Care, ISNCC, also have great position encouraging oncology nurses to support cancer care in low and middle income countries and reduce the global burden of cancer. Because nurses can support, in research. So having a collaborative research with nurses across the globe will be very significant as we enhance the quality of care that we give to our patients. Also providing education to nurses in low and middle income countries. So for most nurses, how I started is following volunteering my time to, medical missions. So that's how I started. When I was a clinical nurse in the inpatient gynecology, I follow them for medical mission in Nigeria. So that's how you start. And then we have a great organization here where we are able to participate in global academic program and also the ECHO project. So like during the COVID time, we have to offer COVID protection PPE in the Cameroon ECHO so that nurses in Cameroon and other African countries were able to utilize what is available for them for PPE because they don't have what we have here at MD Anderson. So such a collaboration and networking is very significant. Again, we want to help those nurses to gain knowledge, skill, and competencies that they need to provide quality care and effective care in helping individuals at risk of developing cancer or that are already affected by cancer. So I encourage every nurse to participate, and I encourage the physicians to also take the nurses with you as you travel across the globe so that you'll be not only educating the physicians, but also reaching out to the nursing profession. Thank you, Ellen.
Yeah, that's an excellent point, Stella, that nurses should always be included in our teams of medical support that occasionally travel to different places. And we could be better at doing that, but I think we've certainly embraced that. And so I guess I'll go back to you, Kathy. So nurses who are interested in getting involved in global oncology education might think they don't have the skills and the talents needed to be an active and valued member of a team. What competencies do you think are important, and how might people prepare, let's say, for a trip to Nigeria or a trip to Mozambique or a trip to Nicaragua?
Oh, that's a great question. I guess you just really have to keep your eyes and ears open and pay attention and attend everything you can and talk to people and learn as much about the country you're going to before you go there. And then again, when you get there, just observe and see where you might be able to help with something that you have a passion for. So Stella and I had a big conversation about this last night, about, before you go into global health, you don't, it's not kind of like on TV, you know, you need to have something that you really have a passion about, that you're interested in enough to put your heart and soul into it, because it's really not easy most of the time when you travel, and physically, mentally a little bit challenging sometimes. So it's so very rewarding. But the thing to be prepared, I think, is to really, you know, seek inside yourself what it is that how would you like to help, and then try to try to, you know, gain the skills for that. Like cervical cancer prevention interests me because I've taken care of patients dying from cervical cancer, which is a totally preventable disease, and it's a horrible way to die, and you never want somebody to have that happen. So I have a passion for preventing that, because if I can prevent one case, it just could be an amazing life-changing thing. So if, you know, I don't know if I'm really answering your question, but that's my approach, is that then I, you know, learned how to do colposcopy biopsy leap so I can help others, and then they can help others, and you know, it just kind of grows from there. So unfortunately, nurses, we have at this time, to help globally, we're still trying to learn our way ourselves, because there aren't a lot of resources, and so we all have to work to try to establish pathways as we go, and then bring others with us. I wish I could be more helpful, but you know, there's an international Council of Nurses that meets yearly and has RNs, but also an advanced practice group. But just, I think you just have to really try to look around you and see what you're able to do, and just, you know, raise your hand. My husband always says, quit raising your hand, but you have to raise your hand. You know, it may be nights and weekends or your vacation or whatever, and you have to be willing to do those things as well. So it's totally worth it. It's wonderful, but we are evolving. And nurses, remember, we are the most, for 19 years in a row, the most trusted profession. So, you know, I have to throw that in there for nurses, because this last year was the year of the nurse, and we kind of missed that with the pandemic. So patients sometimes trust us differently. Not that doctors aren't wonderful and fabulous, but we have a little bit of a different relationship sometimes. So sometimes working with the doctors, we can, you know, bring information that's very helpful as well as part of the team. So anyway.
Thank you, Kathy. And Stella, I'm sure you have a little bit to add.
Yes, as we all know, the demand for global oncology education and training from low and middle income countries is really overwhelming. So how can we reach out to make sure that we provide much needed education to these countries? So for nurses that are you know, asking questions or trying to start. So you start by volunteering your time and your effort and sharing your knowledge with those that are in need. Like Kathy said, you must have that compassion, and you must have the need to do, you know, to help others because it is your time, and it's actually rewarding. So for most countries, like the high income countries such as we are, so you volunteer if you're in academic medical centers. So you will see a group just like we have here, the Global Academic Program, participate in it and see where you are an expert, so that you can network with the physicians and other medical team to follow them to wherever that they're going to provide care. So some cancer centers, even some schools do also organize, you know, clinical teaching, mentoring, and continuous education. So it is important that you find where your passion is and be able to participate as much as you can. So for my part, it's not only educating the nurses and healthcare professionals, but organizing train-the-trainer program as we go to different countries and hospitals is very important, because we don't want what we have put together when we leave that particular country, it will die. So we want them to continue the foundation that we have laid for them, and then we can continue to network with them. With the recent Zoom and ECHO projects, I think we don't have any reason not to network. And also some research studies. So I have a research on HPV vaccination that I'm networking with, you know, a nurse in Nigeria to put something together, you know, for a manuscript. So the sky is our limit on how much we could go with global health. Thank you.
Thank you, Stella. And we're coming up to the end of our 20 minutes, but there's a question about, for you, Stella, about how you modified the work that you're doing because of the travel restrictions related to COVID. And did you make any changes?
Actually, it was really very interesting that COVID did not stop what we're doing. So one thing that I love about our institution is the Project ECHO. So in Project ECHO, for palliative Project ECHO, we were still able to continue. So our woundostomy care nurse was able to present, wound care at end of life. And also in the Cameroon ECHO, like I mentioned earlier, we're still participating in that. So we had several presentations that is nursing focused, especially the last one we did with PPE. So when we also talk about global health, the way that you present to an institution in Africa is different to the way that you teach the nurses here at MD Anderson, because you have to realize what are the resources available to them there. So you can't tell them to use an equipment that they don't even have. So such discussion was very interesting during the COVID era, because they were able to utilize what they have. We have scarcity of masks. They were able to sew their masks using the African materials that are available, and they have tailors that can make it for them. So such network is very significant because at the end of the day is to enhance the quality of care and also protect the healthcare workers. So COVID and travel restrictions, although they affected the progress, but it did not really prevent that. Thank you for asking such a question, because it's really interesting that we should continue what we're doing regardless of the restrictions in travel.
Okay, thank you so much, Stella and Kathy, for your insight and for your participation and for the work that you do, and really appreciate you participating in this section. Back to you, Kathleen.
Thank you.
Thank you.
Great, thank you, everyone. We're going to take a quick break. It's 10:22 Houston time right now, and we'll be back at 10:30, where our next session will be run by our fabulous trainees, fellows and residents, and students in different areas of oncology. So we'll see you back in about 8 minutes. Thanks. Welcome back, everyone. I'm pleased to introduce our next session, which will be the role of physician trainees in global oncology. We're lucky today to have representatives from surgical oncology, medical oncology, radiation oncology, both residents, fellows, as well as students. So without further ado, I'll hand it over to Hankun, are you starting, or Daria?
We're just going to play our recording of all our sessions placed together. So I'll go ahead and play that.
Great, thank you.
And we don't hear the audio, so you might need to share again and make sure that you're sharing computer audio.
You can't hear?
I could not. Maybe others could, but I could not.
No, I could not either.
Best thing to do here is to go ahead and stop sharing. And then when you reshare and you get that first white pop-up box, on the very bottom left, there's a checkbox. There are two of them. One of them says share computer audio, and then one of them says optimize video. Don't do optimize video because Zoom hasn't caught up with that feature and it does the opposite. But go ahead and make sure that checkbox is checked and try it again.
Hi everyone, my name is Daria Kizabun. I'm a first-year Hematology Oncology Fellow at MD Anderson. Welcome to this trainee section of our satellite session. We're going to be talking about trainee global oncology projects and initiatives here at MD Anderson. I have no disclosures. Here's the outline of our satellite session. First, I'm going to talk about why global oncology is important and why we as trainees at MD Anderson are excited about it. Next, my colleagues are going to discuss the activities of the GME House Staff Senate Global Oncology Subcommittee that we all founded together. We're going to discuss trainee research projects in global oncology, followed by a discussion of common themes, challenges, opportunities, and next steps, and followed by a Q&A and discussion. OSCO defines global oncology as collaboratively addressing disparities and differences in cancer prevention, care, research, education, and the disease's social and human impact around the world. Why is global oncology important? You can see from this figure that there's a vast difference in cancer incidence and mortality between high-income and low and middle-income countries. You can see the high incidence of cancer in Australia, North America, and North and Western Europe, and the comparatively low incidence as a result of early diagnosis and good access to treatment. And by comparison, in Central and Eastern Europe, Asia, Africa, the Caribbean, and South America, you see a lower incidence of cancer because the population is younger, and a comparatively higher incidence as a result of late diagnosis and insufficient access to treatment. So there's a lot of work for us to do to be able to bridge these disparities in cancer outcomes. If we continue on the current course, by the year 2040, cancer incidence in low and middle income countries is going to rise significantly as people live longer, and mortality as a result of cancer is going to increase at an even higher rate than incidence. So for example, in Asia, cancer incidence is going to rise by 59% and mortality by 69%. In Africa, incidence is going to rise by 47% and mortality by 77%. So again, there's much work for us to be done. There are already programs ongoing, but an even greater need for development of novel interventions and technologies for cancer early diagnosis, monitoring, and treatment in LMICs. Again, there are projects ongoing, but a great need for capacity building to improve access to surgical oncology and radiation oncology, as well as to optimize chemotherapy use in LMICs. Healthcare policy can be tailored to improve access to cancer diagnosis and treatment, and implementation science and community participatory research can help with the design and implementation of programs that are responsive to community needs and resources and are sustainable. Global oncology requires multidisciplinary collaboration, and we can all learn from each other, where innovations in cancer early detection and treatment for low and middle income countries can then be used in high income countries to bridge healthcare disparities at home. For a patient newly diagnosed with cancer, there is no reason why their survival or quality of life should depend on where they are born. The global community was able to come together to face the enormous challenge of HIV/AIDS and ensure almost universal access to diagnosis and treatment in this case. There's no reason why we cannot come together again to ensure the same improved outcomes in cancer care for our patients. And we as trainees feel that we have an important part to play in addressing these challenges. So during the satellite session, we're going to talk about activities by trainees at our institution related to global oncology that have generated substantial excitement across MD Anderson. We're going to discuss the activities of the GME House Staff Senate Global Oncology Subcommittee that we all founded together. Dr. Cameron Gaskill and Dr. Allison Martin are going to discuss the trainee and faculty global oncology interest survey results. Dr. Hyun Koon is going to discuss the global oncology grand rounds, and Dr. Chidingma Anakwenze is going to discuss the global oncology certificate for trainees across different programs at our institution. We're going to discuss trainee research projects, including Dr. Isabel Zaire, who is going to talk about translating effective HPV education and vaccination administration to low and middle income countries. Dr. Kevin Dow is going to talk about the clinical research course for oncology registrars in Cancer Diseases Hospital in Lusaka, Zambia. And I'm going to talk about breast cancer epidemiology and treatment in Cote d'Ivoire. We're going to finish with a discussion of common themes, challenges, opportunities, and next steps, as well as a discussion and Q&A. And without further ado, I'm going to pass this on to Dr. Cameron Gaskill to discuss the activities of our Global Oncology Subcommittee.
Hello, and thank you all for the honor of speaking to you about a few interests we have been fostering at MD Anderson Cancer Center here in Houston, Texas. My name is Cameron Gaskill, and I'm a second-year fellow in surgical oncology and one of the chairs of the newly formed Subcommittee on Global Health in the MD Anderson House Staff Senate. Many of you will be familiar with the 2018 NCI Center for Global Health Survey. Among many findings, this work documented that 33 of the 67 responding NCI designated cancer centers had global oncology programs at their institutions. The focus of these varied, but with a significant number of programs dedicated to global oncology research, in-country capacity building, and collaboration with international partners. Less so were programs with major focus on trainee education. Despite this, education, research training, and mentorship for trainees is well recognized as an important aspect of global oncology, and global oncology activities for trainees are not uncommon. 27 of the NCI designated cancer centers provide varying amounts of education, with 11 programs providing more than 8 hours of curriculum addressing topics within global oncology. Practical experience are not only valued, but feasible, with 17 programs having had trainees go abroad for global oncology rotation. And finally, a significant contingent of programs have dedicated resources in the training of practitioners from LMICs, either as enrolled trainees in US-based programs or via international partnerships. The NCI survey also showed the wide range of trainee specialties interested or engaging in global oncology activities. Many of those interested in making global oncology a part of their career participate in formal training. These findings have been corroborated in several studies across medical oncology, surgery, gyn-onc, and pathology. The importance of addressing trainees' interests with appropriately rigorous training in global oncology has been stressed in the ASCO Academic Global Oncology Task Force recommendation. This task force went about reviewing ACGME requirements to ensure that flexibility was present to allow students to participate in global oncology curriculum, including experiences abroad while in training. The ACGME clause of encouraging innovation has allowed many programs to adjust and accommodate such experience. In fact, the importance of global oncology training makes up the first of the task force recommendations. This includes the promotion of opportunities within global oncology, cross-disciplinary collaboration of oncology subspecialties, outlining competencies in training, and creating global oncology resources accessible to program and trainees. On the basis of these ASCO task force recommendations, trainees at MD Anderson created the Subcommittee on Global Oncology. Historically, global health activities among trainees have been disjointed and independent. In forming this group and having it voted on and formally recognized at the level of the House Staff Senate, we have fostered a home for collaboration of trainees across specialties with the goal of encouraging global oncology activities in our training. Our mission statement includes the following: raising awareness of current challenges and potential innovative solutions in care in LMICs, promoting multidisciplinary collaboration among House staff and faculty through fostering networking relationships and raising awareness of existing clinical and research opportunities in global oncology. And finally, developing clinical and research opportunities for trainees through existing partnerships and creation of new collaborations, as well as advocating for institutional funding to support these projects. One of the first tasks we approached was administering a survey across trainees at MD Anderson to better assess interest and involvement in global oncology. We created and distributed a brief REDCap survey via email to all trainees, both clinical and non-clinical, such as biostatisticians and physicist programs, in total contacting around 300 individuals. The survey was structured to explore 5 themes. 1, their involvement and interest in global health. 2, any experience or involvement in global health and specifically global oncology. 3, career aspirations as pertain to global activities. 4, global oncology opportunities while training at MD Anderson. And 5, perceived obstacles to engaging in global oncology experiences while in training. Overall, 72 trainees responded, with 33 or 46% indicating an interest in global health. Those interested spanned a wide variety of specialties, 17 different training programs in total. Most common were trainees in medical, radiation, surgical, and pediatric oncology, and there was a representation in non-clinical fields such as cancer prevention research and investigational cancer therapeutics. Of those interested in global oncology, 58% had prior experience with global health. These activities were most commonly clinical in nature, but also include significant experience in research and advocacy. Most of these trainees had around 1 year of experience in global health, however, ranged up to 15 years of experience for some. However, despite the large interest in global oncology and a fair number of trainees with global health experience, only 8 trainees attested to having prior experience specific to global oncology. Furthermore, despite such few with experience, 60% of respondents wish to dedicate a significant amount of time to global oncology as faculty at their future jobs, with majority wishing to spend between 10 and 20% of their time on global oncology activities. Among trainees interested in global oncology, there was overwhelmingly interest in making such activities part of their training. More than 3/4 of respondents wish to engage in research collaborations focused on global health issues. 70% desired education in global oncology, including formal coursework, grand rounds, and even informal events like global health-focused happy hours. And 64% of trainees were interested in engaging in both clinical and teaching experiences abroad. When asked about what resources they thought would enhance their global oncology training, a majority desired research focused in global health issues, increased access to mentorship, clinical opportunities, and formalized global oncology coursework. The final question addressed what obstacles the trainees perceived in global oncology. General themes included a focus on health disparities in LMICs, challenges around cancer prevention, detection, and treatment in low-resource environments, and building long-term partnerships. Training-specific themes identified the difficulty in finding appropriate mentorship, and long-term concerns included concerns for securing dedicated, protected time and funding for projects. With this data in hand, our subcommittee has focused its efforts on addressing the issues raised by this survey, many of which will be presented today, such as connecting trainees to faculty engaged in global oncology projects, the creation of virtual global oncology grand rounds, and formalizing a global oncology track curriculum for trainees at MD Anderson. Furthermore, this survey had the unintended results of recruiting 17 additional trainees to our subcommittee. Our subcommittee is now one of the most active factions of the House Staff Senate and helping to connect trainees to the larger global oncology community involved with the Global Academic Program and Cancer Network based at MD Anderson Cancer Center. Thank you all again for the honor of speaking about our trainee interest and efforts in global oncology. We will be happy to discuss any questions after the remainder of our presentation.
Good morning. My name is Allison Martin, and I'm a surgical oncology fellow at the University of Texas MD Anderson. This morning, I'll be presenting a survey assessment of faculty involvement and interest in global oncology. In order to gauge interest and involvement by MD Anderson Cancer Center faculty in global oncology in low and middle income countries, a survey was sent in fall 2020. All MD Anderson faculty were invited to complete the survey through REDCap by email invitation, and there was no consideration given to specific clinical and research focus in global oncology. Anyone was welcome to fill out the survey. Our institutional trainee-initiated faculty survey included several themes, which included assessing faculty current involvement in global health, interest in participating in future global health activities, and institutional resources for supporting global health. In total, 82 surveys were completed amongst all faculty who received a survey. Of the 82, 72 or 88% indicated an interest in global oncology as part of their primary academic portfolio, and their survey results are presented here today. The primary professional responsibilities indicated by those 72 participants included 76% reporting clinical responsibilities, 64% research, and 53% reporting administrative responsibilities. Our survey results highlighted several themes in global oncology. The first theme was a current involvement in global health by our faculty respondents. Respondents were asked to respond to the statement, I currently have research projects that focus on global oncology. 31% of respondents agreed with this statement and highlighted research areas and disease-specific groups where their research focused in global settings. For example, one faculty member shared that they had created a pilot international comprehensive breast imaging curriculum with self-assessment available for radiology residents in collaboration with MD Anderson academic partners at a comprehensive cancer center in Singapore, while another described outreach through Project ECHO in Latin America, Mozambique, South Texas, with a focus on cervical cancer prevention. Respondents were also asked to agree with the statement, I currently have training and education projects that focus on global oncology. 38% did so, and highlighted projects involving Project ECHO, research and training partnerships with faculty and trainee partners in low and middle income countries, quality improvement projects, and bilateral exchanges for both trainees and faculty. The second theme of the survey was interest in participating in future global health activities. Respondents were asked, are you interested in participating in the following global oncology activities? The majority were interested in collaborative research projects with partners in low and middle income countries, which is an expected outcome of our survey. In terms of participation in multidisciplinary tumor boards with partners in low and middle income countries, just under half were interested in pursuing this type of initiative, and several reported that they had active ongoing research projects in this area. Education and training of clinicians and researchers was also investigated, with a higher level of interest amongst education and training of clinician versus research, indicating an interest in pursuing clinical activities related to decreasing the burden of cancer in low and middle income countries. Many were interested in participating in in-person or virtual lectures and grand rounds or journal clubs related to global oncology, an area of interest that our trainee organization for global oncology has capitalized on, and that my colleagues will talk about further during their presentations. In-person or virtual informal meetings and happy hours with other MD Anderson faculty and trainees interested in global oncology was also an area of higher interest. And though this area is challenging in the midst of the COVID pandemic, we are looking for ways to expand our social interactions among folks at MD Anderson that are interested in global oncology. The third survey theme was institutional resources for supporting global health. Respondents were asked, what resources at MD Anderson do you believe would enhance global oncology research and activities for faculty? Respondents included funding, protected time, and credit towards promotion as areas of highest interest, with extramural time, administrative support, and mentorship also receiving significant interest. Respondents were given an opportunity to provide free text responses to questions regarding future interest in their involvement in global oncology. The first theme was building bridges with international partners. One respondent commented on focusing on rare cancer research. They said, I believe a fellowship abroad will cement the relationships among MD Anderson staff and low and middle income country participants for future engagements. Another respondent said, if an LMICs investigator is looking for potential collaborators, GAP, or the Global Academic Program, could post that need to the faculty community at MD Anderson. These faculty responses indicate broad interest for building collaboration with LMIC partners in multiple areas. Regarding interest in institutional support of global health activities, respondents had multiple areas where we could provide improvements, including comments such as, can we expand the annual appraisal or institutional curriculum vitae to somehow incorporate discussion of international efforts so it's more visible to our department heads who may not realize how much effort is being expended. Another said, given the continual interest of our trainees and trainee applicants in global health, having departmental faculty with focused interest would be ideal to allow mentorship. Placing value on hiring for that skill set would be helpful. There are several themes such as these that integrate very well with the results of our trainee survey, as was previously presented. Finally, faculty were able to comment on supporting research lab and ancillary capacity building in global oncology. One said, I think training teams on the emerging disciplines of data science and machine learning will equip our clinicians with modern tools used in research. Another said, I think this should be a banner goal of the entire global program, to study, learn, assist, and evaluate in order to develop a working model for effective cancer prevention screening, early diagnosis, treatment, and survivorship in underserved communities. Those actions can be subsequently tailored for use in any other underserved community, domestic or foreign. In conclusion, our survey results indicate that faculty want more opportunities and greater institutional support for both their research and clinical efforts in global oncology. And that includes support and recognition of their efforts being counted towards academic promotion. Furthermore, integrating both faculty and trainee interest is critical if we are to create programs and clinical research efforts that are sustainable with our low and middle income country colleagues. Thank you, and I'm happy to answer any questions during the discussion portion of our session.
Hello, my name is Han Kuhn, a second-year gynecologic oncology fellow at MD Anderson, and I will be discussing development of a novel virtual global oncology grand rounds during a pandemic. I have no disclosures. My objectives today will be to discuss the initiation of our virtual global oncology grand rounds, review the advantages of our program, as well as the challenges that we have encountered, and discuss the potential future directions. As you all know, COVID-19 drastically changed the work environment for all of us. At our institution, since last spring, we issued prevention guidelines which limited workplace gatherings. And like many other places, we began to regularly utilize a virtual meeting format. Although many of us encountered the necessary learning curve associated with virtual teleconferencing, we quickly adapted to the system and have tried to optimize its use. In particular, I think one previously underestimated benefit of this technology is that it ultimately allows our collaborations with those who are local, but also throughout the nation and the world. As previously described, amongst our trainees at our institution, there's been a growing desire to form a group committed to global oncology, thus the formation of our subcommittee. We aim to accomplish many objectives, including hosting global oncology grand rounds. The overall goal of the grand rounds was to highlight global oncology efforts that have been implemented throughout the world. We decided to use Zoom, a video and teleconferencing technology for which our institution has a license, and also because we still are in the midst of a pandemic. As a trainee-led organization, we hope to target other trainees at our institutions who share interest in global oncology, but also anyone else who might have a passion in global health. The last component for implementation that I will mention are the wonderful speakers that we've had the pleasure of hosting. From the start, our group wanted to share experiences and lessons from mentors, collaborators, and those who have experienced their own global oncology journey. And we've been fortunate as trainees with ties to other institutions to be able to reach a vast list of potential speakers from across the country and the world who would be able to discuss their implementation of these global oncology initiatives. Our first session was in December of 2020, and we have incorporated a number of specialists from across the country in various disciplines. Our global oncology grand rounds are typically scheduled for an hour, but the discussions are so engaging, we often find ourselves continuing for well over the allotted time. Some of the common themes that have arisen from these presentations and discussions have been their interest in global oncology, how to build collaborations, their path to pursuing a career incorporating global oncology, the challenges to this pursuit, and what advice they have to overcome these challenges. So to begin the year, we had Dr. Kathleen Schmaeler from MD Anderson provide the inaugural talk, highlighting her important work in cervical cancer prevention in Brazil, collaboration in Mozambique, and global efforts through Project ECHO. And most recently, we had Dr. Surbi Grover, a radiation oncologist from the University of Pennsylvania, speak about their collaboration in Botswana, where she now does her full-time work. By utilizing a virtual platform, a number of advantages arise, including the ability to invite speakers from across the country, as well as across the world. We do aim to invite more international speakers in the future, which highlights the true global nature of this grand rounds made possible by the virtual platform. Additionally, this also allows us to expand our audience to reach those outside of our immediate MD Anderson community and incorporate our collaborators. And by using the virtual platform, this allows for flexibility for our audience, many of which might be clinical fellows who are logging in from their office space, the OR lounge after they've completed a full day of surgery, or at home. And for our group, this has been a low-cost initiative because of their institutional license with Zoom. However, with the virtual setting also comes its challenges. For instance, virtual engagement can be difficult. Speakers are unable to read cues from the audience to alter the mood, momentum, or engagement based off feedback. And as we incorporate global speakers, conflicting time zones have become a scheduling issue that we continue to work through. And aside from these, there's also the technical concerns and difficulties associated with video conferencing and the dependence of internet availability and bandwidth. So where do we see our grand rounds in the next year or two? We hope to continue to hold these sessions and invite bilateral speakers, hosting domestic oncologists, but also their international colleagues performing work at these sites. And perhaps once safe, we do hope to incorporate a live or in-session component because this may foster networking and discussion on global oncology projects. We hope that ultimately through this platform, we will continue to learn from others as our trainees start their own journey in global oncology. Thank you for your attention and the opportunity to share our experience with this novel initiative. Thank you.
Hello, everyone. My name is Chidinma Quenze. I'm a fourth-year radiation oncology resident at MD Anderson. I'm excited to talk to you all today about something we've been working on for a few months, a global oncology pathway for trainees at MD Anderson. Brief overview of why we decided to create this pathway. As Dasha and Cameron mentioned, there's been a growing group of trainees at Anderson who are really passionate about global health. We saw some unique challenges in creating an academic pathway for ourselves. And so we decided to create a global oncology track or pathway to help trainees craft careers in global oncology. So we set out to create a robust curriculum to help Anderson trainees become leaders in global oncology. We envisioned that this track would encompass multiple subspecialties in oncology, so rad-onc, gyn-onc, surg-onc, medical oncology. And now ASCO outlined some goals or competencies for global health training programs. And we adapted these competencies to come up with objectives for our own global oncology track. And so trainees that complete this pathway should be able to understand the challenges faced by patients with cancer in under-resourced settings, identify the socioeconomic determinants of cancer outcomes in low-resource settings, understand the challenges of delivering high-quality care in resource-limited settings, and develop skills that are relevant to capacity building and conducting collaborative research or educational projects in under-resourced countries. And also understand the role of oncology physicians in advocating for patients and shaping health policy in low-resource countries. We wanted to make sure that the program was rigorous with a didactic component to help trainees meet the outlined competencies without reinventing the wheel. So we looked at what was already out there. We found that there was a Canadian Association of Radiation Oncologists Global Oncology Enrichment Program curriculum that we could already use. And so this program is 1 year, has a certificate at the end. It introduces some key concepts in global oncology and cancer control, including cancer research, innovation, policy, economics. It really provides an avenue for mentorship from emerging leaders in global oncology. So 1 year, once a month, 1 hour lectures with some short Q&A at the end and a pre-post test as well. And also we're working on incorporating a formalized end of the year assessment that we can add to this that can be tailored towards our trainees at MD Anderson. Trainees are also required to attend research meetings where they discuss with other trainees their projects and their progress. And as Han discussed, we kicked off our virtual grand rounds this past December, and we're incorporating this into the global oncology track through a 50% attendance requirement for trainees in the track. Each trainee is also going to be asked to complete a project through one of the following tracks, either a clinical elective quality improvement track where they do a QI project while on site doing a clinical rotation as well, or they can complete an educational or research project abroad, but they can also collaborate with institutions at low or middle income countries to do their projects remotely as well if they're not able to travel. However, just because you're in the research or education track doesn't mean you can't do a clinical rotation. So we envision that this is a 2-year track, and in the first year, the trainee will be preparing, meeting with potential mentors, networking at Global Oncology happy hours, attending the Global Oncology grand rounds as well. And once they've decided to apply, they would submit their CV, a letter of intent, as well as a training and mentoring plan that has a detailed timeline of how they would use their time within the 2 years of the program. They can also start meeting their Global Oncology grand rounds and their Global Oncology Enrichment Program curriculum requirements during that first year as well, and that continues on to the second year. The second year is more of a practicum phase where they complete their clinical research or educational project, and they also would at this point present their work at formal meetings. So either the Global Oncology Track Annual Conference or the Global Oncology Grand Rounds. In addition to that, we require that everyone would submit either a published manuscript or present at a national meeting, just so that we can have a formalized culmination of their projects presented out to the world. So trainees who are in the track will identify a global oncology mentor in the first year. They'll meet with them every 4 to 6 months to establish like how they're doing with their milestones, how their projects are going. And in addition to that, there will also be some formalized assessments through that Global Oncology Enrichment program that we mentioned. On the right here, you'll just see some of the topics that are going to be covered during that Global Oncology Enrichment program that takes 1 year to complete. And of course, there's the post-course assessment that I mentioned before. And at the end of doing all of these lectures, they'll get a certificate of completion. So that really outlines the track. The first year is the preparatory phase for the trainees, and the second year is the practicum phase. Right now, we're working on testing the curriculum and establishing agreements for clinical and research rotations. Next year will be our inaugural year, and we hope to integrate some pre and post knowledge assessments, some qualitative assessments, and some short reflective essays that will help us gather some data that we can use to apply for funding to support those international practicum experiences. So that concludes my presentation. Thank you all for your time. I'll next hand off to our next presenter. Thank you so much. Bye.
Hi, I'm Isabel Sayre, one of the family med residents over at UT Health. I wanted to talk a little bit today about global implications for HPV vaccination. No disclosures for this presentation. So objectives for the presentation: first, we'll discuss benefits to vaccination and barriers across the globe, which vary widely, and then review a few examples of successful programs, briefly talk about the future implications of vaccination and the ongoing efforts. First, I'd like to talk about the case of India in terms of HPV vaccination. So vaccination has created a great opportunity in India to reduce the burden of cervical cancers, both on a national level and also for individuals. Policymakers and health administrators need to be aware of complementary vaccination strategies, meaning they need to be aware of the technology needed to effectively implement HPV vaccination, as well as the existing infrastructure, especially within rural communities, to carry out those plans. On the right, there's just an infographic briefly to look at. This is a breakdown of the most common reasons for missing among the 38,000 in the case study done on Indian HPV vaccination. Most commonly, awareness gaps, not being aware that HPV vaccination was taking place. And then second most common, and this is a repeated theme in rural areas undergoing HPV vaccination, root cause analysis for non-vaccination, which is fear of adverse events, which can be mitigated with education. Again, looking at barriers. So countries with the highest disease burdens of cervical cancer do not necessarily have the most educational programs for obvious reasons. One great example is in Brazil, specifically Boa Vista, which has a huge cervical cancer burden. A lot of patients who were surveyed both after initiation of the HPV vaccination program there, and then about a year later after the program was completed, a large reason they didn't complete the complete vaccination was simply not knowing that there needed to be a second or third vaccine dose. So education could have been better optimized in that situation. Potential benefits. So kind of the silver lining. Vaccination with full dose administration of either Gardasil or Cervarix, which are the ones that are mainly funded for global vaccination, prevent nearly 100% of women from premalignancy or malignancy cervical cancer that are attributed to high-risk HPV strains. Effective for 4 years, even after just the first dose, and no need to revaccinate. HPV vaccination is safe and effective in prevention of high-grade cervical premalignancies. However, only 13 of the 90 nations who have now mandated HPV vaccination into the national vaccine program are low SES countries. Global benefits, obviously, there is a disproportionate amount of disease burden expected by the year 2040, 20 years from today, in the Southeast Asian population and African populations, according to the WHO Cancer Tomorrow prediction tool. That's where we're going to see a huge increase up to upwards of 60% in those places in the next 20 years. And the WHO actually has, as of 2017, stated formally, all countries should include HPV as part of the standard immunization schedule for adolescents. Another case study on Uganda, which has a 40% cancer burden attributable to cervical cancer, PATH did a study in 2011 that showed school grade-based programs are more successful than age-based programs, just for a simplicity of reaching out to those communities. Effective directions, so limited resource methodology involves targeted vaccination 9 to 14 age cohort of girls, and this is also for the Ugandan example, and the importance of organization. So you need to have members in the community available that are already part of the people you're vaccinating's lives to follow up on missed vaccine opportunities and pre-vaccination education. And a little bit about future initiatives. So key takeaways from PATH and others. PATH is obviously a huge driver in low SES economies and their funding and adverse event coverage. Focus on community outreach before the scheduled vaccination. Set yourself up for success. Make sure that you're using the existing school infrastructure or community infrastructure that's available in that community instead of just going in blind. Gavi, for example, has done an excellent job of identifying high-risk regions, populations, and nations, and successfully used their existing infrastructures to guide expanded vaccine programs for HPV. These are references. Thank you very much.
Hi, my name is Kevin Diao. I'm a radiation oncology resident at MD Anderson, and I'll be talking about implementation of a virtual clinical research course for clinical oncology fellows at the Cancer Diseases Hospital in Lusaka, Zambia. I have no conflicts of interest. This is a partnership timeline between Cancer Diseases Hospital, or CDH, and MD Anderson, or MDA. In 2007, CDH treated its first cancer patients. In 2015, the CDH-MDA partnership was first established. In 2018, the clinical oncology program at CDH enrolled its first group of registrars. And in 2018, the first CDH-MDA radiation biology and physics course was held. In 2020, the pilot CDH-MDA virtual clinical research course happened, which is the subject of this talk. So this was brought about by a significant need expressed by CDH colleagues for a structured clinical research curriculum for trainees. And the initial plan was for the course to be in person, but due to the COVID-19 global pandemic, the course was adapted to a virtual platform. This ultimately allowed for additional faculty members with specific content expertise to be involved in the course. And all senior CDH clinical oncology fellows were able to be paired with a CDH faculty member, a MDA faculty, and a MDA peer mentor who was a resident or fellow. This is the clinical research workshop schema. And as you can see, the first portion involved weekly virtual lectures along with concurrent development of research protocols, followed by joint longitudinal mentorship of research protocols by MDA and CDH faculty with MDA trainees. And in the future, we hope that this leads to completion of research theses, which is a requirement for trainees in their program, as well as submission of abstracts and manuscripts. Now we'll first look at the weekly virtual lectures. There were 14 one-hour-long weekly sessions, which were given by 12 different speakers, including faculty and trainees from both MDA and CDH. And represented were faculty in cancer epidemiology, radonc, medonc, gynonc, clinical trials, health services research, medical physics, biostatistics, and scientific communication. This is the lecture schedule, and I won't go through this comprehensively, but as you can see, there is a wide range of lectures given, ranging from foundational basic topics to more advanced topics. Next, we'll talk about the development of research protocols, and all of these research protocols are being led by the CDH Clinical Oncology Fellows. And as an example, one of them is titled Retrospective Evaluation of Toxicity Outcomes for Two-Dimensional versus Three-Dimensional Planning for Locally Advanced Cervical Cancer Brachytherapy. And all of these topics are highly relevant for the cancer practice environment that these trainees are in. We did administer anonymous pre- and post-course surveys to the participants. And just highlighting some of the results that we had, we looked at different domains of research self-efficacy As you can see, the dark green is the pre-research course, and the light green is the after or the post-research course. And across all of these domains, there was a higher average post score, demonstrating that the research course did help in many of these domains, and that was very encouraging for us to see. We also looked at anonymous open-ended feedback, and just some selected excerpts from this feedback. The course was very helpful for me, who I'm just starting to do my own research. I learned a lot, and I'm hoping for more lectures in the future to better my skill in research. Our research initiative was definitely not without challenges, and one of the main ones was working around the time difference and coordinating meetings, with this being a virtual partnership. One of the ways that we solved this problem was to set regular weekly and bi-weekly virtual meetings in advance and to reschedule as needed. There also wasn't enough course time spent on foundational topics, including literature review, data collection, and statistical analysis. Some of our peer mentors have created and or compiled some introductory resources for reference, and we hope to formalize that in the future, as well as better tailor our lecture series. And understandably, there's different career goals and levels of interest in clinical research among the participants. And one way that we plan to address this in the future is to stratify the course with more intense support for those with a greater interest in clinical research. In summary, an established, proven partnership was the foundation for this initiative. And while COVID-19 presented significant challenges, it ultimately led to a stronger workshop by allowing for increased participation from faculty members and trainees. The workshop was only possible through international, multi-specialty, and multidisciplinary involvement. It really took a team. And we encountered many challenges along the way, which stressed the importance of 1, program evaluation, 2, a strong partnership, and 3, a bilateral focus on improvement. In the future, we plan to make the virtual clinical research course annually recurring with longitudinal mentorship, and we hope to have an in-person component when feasible. We'll integrate a web-based platform featuring individual self-assessment modules and group learning protocol development projects. And we hope to develop partnerships to scale the program and include trainees from other regional oncology training centers in subsequent years. Thank you so much, and I'd love to hear from anybody with questions or comments.
Hello again, everyone. Before I became a fellow, I had the opportunity to work with Dr. Dan Marcelin Homian, the chief of the chemotherapy unit at the teaching hospital in Traceville, Abidjan, on a study to describe breast cancer epidemiology and treatment in Cote d'Ivoire, a country of 25 million people on the west coast of Africa. Breast cancer is the most common cancer in women in Cote d'Ivoire, and a study done in 2008 to 2011 found that over 80% of the women presented 10 months or more after noticing symptoms as a result of lack of financial means, consulting a traditional healer first, or diagnostic delays and errors or decreased access to medical care. 3/4 presented with stage 3 disease and 15% with stage 4, and over 3/4 presented with skin findings of advanced disease, including skin inflammation, ulceration, and necrosis. Cote d'Ivoire has 3 mammography units and 6 pathology laboratories. The first oncology department was founded in CHU Traceville in 1993, and another one was added at CHU Cocody in 2017. There are many challenges related to breast cancer diagnosis and access to treatment in Cote d'Ivoire due to low awareness in the population about signs and symptoms of breast cancer, low awareness of cancer signs and symptoms among frontline medical personnel, an insufficient number of pathologists and oncologists, insufficient number of immunohistochemistry reagents, and only 40% of the population able to afford treatment. The government is trying to address all of these issues, but there's still much work to be done. We did our study to describe the presentation, treatment, and outcomes of breast cancer in Cote d'Ivoire, 10 years since the last study, and to compare the treatment concordance with NCCN harmonized guidelines for sub-Saharan Africa. It was a longitudinal study in a sequential sample of 30 women diagnosed with breast cancer at CHU Traceville from March to September 2018, and then we looked again in February of this year to see how the women were doing. Most of the women presented 12 months or later after noticing symptoms. Most had breast cancer risk factors, including multiparity in half, and family history of breast cancer, diabetes, or hypertension in a third. 45% of the breast cancers were hormone receptor positive, a third were triple negative, and a fifth were HER2 positive. Women presented at a younger age with a median age of 49. 46% were diagnosed with stage 3 disease and 40% were metastatic. There was a high number of patients with metastatic disease compared to the previous study because CT scan was used for staging instead of chest X-ray and ultrasound in the previous study. Here you can see the treatments that women received, whether they were able to afford treatment and if they're still alive. You can see among women with stage 2 disease, most received surgery, adjuvant therapy, including chemotherapy and radiation, and all were still alive. On the contrary, among women with stage 3 disease, you can see that many progressed despite anthracycline-based neoadjuvant chemotherapy, which is the most aggressive chemotherapy that we have, or shortly after mastectomy. Unfortunately, many reached a time when they were no longer able to pay for cancer treatment and then passed away. Fortunately, many who progressed were able to receive palliative care because there's a collaboration with Uganda where oncologists in Cote d'Ivoire are able to go and receive training there. Among women with stage 4 disease, you can likewise see that some were able to respond to frontline chemotherapy and receive a palliative mastectomy, but many progressed after receiving chemotherapy, and many died or were lost to follow-up, and many were also not able to afford treatment. A good portion received palliative care. Radiation therapy was concordant with NCCN treatment guidelines. Surgery was concordant except for mastectomy and metastatic disease, which we also do in the United States for our younger patients. And chemotherapy was generally concordant except FEC was used instead of AC. We know that the two are equivalent, but FEC is more toxic, but we do not know if they are equivalent if paclitaxel is used less frequently than the recommended weekly dosing as it was in Cote d'Ivoire, since many of the patients could not afford the weekly treatment. The FEC ×3 followed by docetaxel ×3 is not in the guidelines, but was used because it was found to be cost-effective in studies out of Europe. Doxorubicin cisplatin is not in the guidelines, but was used because local oncologists noted that it's effective in refractory disease, and now there's a clinical trial underway to test this. And other regimens were used due to a carboplatin shortage. There are many future research questions that we would like to address based on our results. For example, we would like to see, does chest X-ray and ultrasound understage cancer compared to CT scan? Why is it that women with stage 3 cancer appear to be more resistant to anthracycline-based chemotherapy? This is much higher rate than we see in our patients, including our African-American patients, and then looking to see can doxorubicin cisplatin be used in refractory disease, as well as other questions. Based on our findings, we recommended that cancer early diagnosis interventions be implemented in primary care centers and prenatal clinics, since many of our patients had many children and hypertension and diabetes, so would be going there for care. There's ongoing work with NGOs, private companies, and religious organizations to improve cancer awareness and early diagnosis, as well as access to treatment, as well as working with drug manufacturers to make drugs more affordable and in a sustainable manner. There's a need to create guidelines adapted to daily oncology practice, and it's important for English-speaking and French-speaking countries in the region to collaborate and share experience, including innovations that they come up with. Dr. Homian was invited to be part of the ASCO Research Stratified Guidelines Committee for Breast Cancer, so we will see the outcome of that. And we also applied to the NCI Implementation Science Training Workshop to develop a proposal for breast cancer early detection into a grant. Dr. Homian and his colleagues asked for additional training in clinical trials and other research methods, and ASCO put together a training workshop for them this summer that I'm going to help facilitate. So I would like to thank Dr. Homian for this opportunity and to all of you for listening. Next, I'm going to switch gears and summarize common themes in global oncology that my co-trainees and I have encountered, both as part of our work on the Global Oncology Subcommittee and as part of our research. We see broad interest in educational research and capacity building opportunities in global oncology among both faculty and trainees at our institution, compared to other academic programs that have long-standing relationships with academic institutions in low and middle-income countries where faculty and trainees can go and do clinical work or research. We actually have limited experience in global oncology here at MD Anderson. Some faculty are doing innovative and impactful work, but many are working in silos. And we think it's important to broaden these to collaborate across multiple disciplines, to share ideas about projects and common challenges. We have actually been doing this as part of the Global Oncology Subcommittee. We've shared the research that we're doing and the challenges that we have encountered, as well as grants that we're applying for. And this has been enormously helpful because often if one person has encountered a challenge, others have an idea about how to address it based on our own experience or something we've read or heard about. And sometimes there can be a reluctance to do this because there are limited grant opportunities in global oncology, but really we have found sharing of our experience and asking for feedback to be enormously helpful. We can really accomplish so much more together. We do need greater institutional support for faculty and trainees interested in global oncology, either making it a central part of their career or just exploring their interest in this field. And to do this, we need to build formal relationships with institutions that have established global oncology programs or build our own. Many of us have gone into global oncology because we saw the vast disparity in cancer outcomes, and we're hoping to use our skills and knowledge to help. We were often surprised and humbled because we saw that sometimes the great ideas that we or our mentors have do not fully work because of vast differences in healthcare systems between the United States and our partners in low and middle income countries because of different cultures or political realities. But we have also been inspired by the persistence and creativity of local oncologists and nurses, patient advocates and survivors who are often having to raise money to make treatment more affordable to patients and to advocate in front of local politicians. And this has inspired us to tackle these challenges that previously would have seemed insurmountable. I think it also helps us in taking care of our own patients to appreciate the resources we have and to think about how can the things that we learn with our partners in low and middle income countries be used to bridge healthcare disparities at home, because many patients are still diagnosed late with cancer, particularly in underserved communities. Many still face a high financial burden of cancer care that can affect their quality of life and even survival. And this is both uninsured patients and underinsured patients, and even those with good insurance. We have seen the importance of local needs, existing resources, and competing priorities in ensuring the design and implementation of programs to improve cancer care. And we have seen how essential local leadership and ownership are in ensuring program sustainability. It is really important to empower local oncologists, nurses, and patient advocates with any knowledge and technical assistance that they need to address the problems on the ground to improve care for their patients, because they're the ones who know what their patients need. They know the gaps in the healthcare system, and we're just there to help and learn from each other. Multidisciplinary collaboration, including with local civil society organizations and patients advocates, who often are the ones to advocate for increased funding from ministries of health and local politicians, and with international cancer-focused organizations that can often provide educational resources and technical assistance, is really important. It's important that we're aware of the work each other is doing to avoid duplication of efforts and common pitfalls. Some challenges and opportunities that we have encountered during our work include continued negotiations with the GME related to time away, either or time or continuity clinic, and continued salary support while in another country. We're still working out some legal and financial hurdles related to away rotations, but so far our program leadership has been very supportive, and we're just working out some details. Our next steps include cataloging and disseminating existing global oncology opportunities at MD Anderson, development of trainee research proposals for the Global Oncology Certificate that will include time away in low and middle income countries at established programs or some of the partnerships that we have established ourselves, refinement of the Global Oncology Certificate curriculum and tailoring it to individual programs, and continuing the Training Global Oncology Research Meeting and Happy Hour to discuss individual projects, troubleshoot, and discuss conference and grant opportunities. We're continuing to advocate with the GME for funding of trainee initiatives, and we're planning to advocate to establish institutional grants related to global oncology. for faculty and trainee projects, the same way that we have grants for basic science and clinical trials. In the future, we would like to establish a formal partnership between MD Anderson and the Cancer Diseases Hospital in Zambia, with the goal of submitting joint grants and also having joint training opportunities where trainees can go into Zambia to observe clinical care or participate in research projects, and oncology registrars and faculty can come here for any training that they might find useful. So with that, I would like to thank everybody who has been instrumental in the work of the Global Oncology Subcommittee, particularly my committee co-members, Cameron, Chiding, Mahan, Allison, Kevin, Lauren, and Taiwo, our wonderful mentor, Dr. Kathleen Schmaeler, all of our program directors, and our research and clinical mentors, as well as the GME House Staff Senate and Global Academic Programs. And thank you very much all for listening to this session. Let us know if you have any questions.
Thank you all. That was really a terrific session, and a big congratulations to our trainees. Although this seems like years of work, they just formed this subcommittee earlier this year and have really engaged all the trainees, but also the faculty and the leadership to show interest in global health. Are there any questions at all? Can you hear me? Okay. Says my internet is unstable, so I'm just double checking. Any questions at all for the trainees? Any questions in general? We have about 30 minutes for discussion and questions. So I'll open it up to anyone with any questions, and if not, I have several. Melissa, you're muted if you're speaking.
Yes, I was thinking that, thank you, Kathleen. One question people might ask is, how can they get involved as trainees, as nurses, as physicians? So maybe something for all of the panelists and faculty, if they have any thoughts about others and how they might get involved if they're interested in collaborating with all these programs.
So one quick answer is to attend the global grand rounds that our trainees have put on. I think that's an excellent way to learn more, both about what we're doing at MD Anderson, but also we've learned so much from our outside speakers, from what Memorial Sloan Kettering is doing, University of Pennsylvania, and you'll see many upcoming talks. So I think that's one way. Another way, regardless of what discipline or what area you're in, would be to join some of our Project Echoes. We have several in several different countries across different time zones. I don't know, Ellen or Melissa, if you want to talk a little bit about them and the possibility of joining to learn more.
Yes, I can start, and Ellen, you can complement, but we have many Project Echo programs, some specifically focused for cervical cancer prevention in Texas, in Cameroon, and in Mozambique. And we also have a program for public health and cervical cancer in Latin America. And so they are across different time zones, but anybody, as Dr. Schmaeler said, can join to observe, but also to participate as faculty or case presenters if people are interested. I know others at MD Anderson also host Project Echo programs. For example, Dr. Jean Grant and Dr. Sadabwe from Zambia have a Project Echo program specifically for radiation therapy in Zambia, and I know others within the region are invited if interested. Ellen, any other thoughts?
I thought maybe I should just spend a moment and define Project Echo, because I'm not sure everybody's familiar with it, but it is It is a model using video conferencing to connect with colleagues around the world and around the community, but essentially the thought behind Project ECHO video conferences is to connect specialists, who we call maybe the hub, with colleagues in regions where specialty care is not available, and provide support and guidance for how to treat patients locally who might otherwise be referred. So it's a video conference that has a particular aim of building capacity in areas where specialty care is scarce, and to create a professional network and help to build capacity for treatment of diseases otherwise, and patients who would otherwise be referred. So that's sort of the Project ECHO in a nutshell. So many different disciplines and many different specific programs fall under the Project ECHO umbrella. It covers virtually every aspect of healthcare. There's hundreds of these programs that work both within the US and around the world. And it's an excellent way to get a good understanding of what the challenges are of providing care. For example, if you're connecting with someone in Zambia or someone in South Africa or someone in Bolivia. So it's just a tool to improve communication and build capacity.
And it's also nice because during the COVID pandemic, while we can't travel, it's a great way to be able to learn more, to join from the US, and especially for, you know, our trainees, many of our clinicians, really everyone's so busy. So it requires a pretty limited commitment to start, and then you can learn more about the different projects and the different challenges in different places. We're lucky to have Sharon Byrne, who's participating with us from Cooper, who was telling me a little bit about a program that she's involved with in India. I don't know, Sharon, if you could just talk a little bit about it and let us know what you're working on.
Sure. Hi, everyone. So I am, as I said, over in New Jersey, and we're part of the MD Anderson network. So the work that I'm going to speak about has really just begun. It was kind of halted related to COVID, but basically in 2014, myself as a advanced provider, nurse practitioner within our cancer outreach department, worked with a network here in New Jersey called the National Indio Cooperative Enterprises, or NICE, and it's in Camden County, New Jersey. And they reached out to us at Cooper about establishing an education and early screening program for cancer for the Asian India women in our community. So we have been involved in that for 11 years. So I run a dedicated clinic each month, particular to the Asian India women. I have a panel of close to 400 patients that I follow. And I've been astonished by the number of non-malignant conditions that I've been able to diagnose, but also the number of breast, cervical, and endometrial cancers that have been diagnosed through the program. So we do cervical cancer screening, breast cancer screening, and colorectal cancer screening. And I work specifically with an Asian Indian lay navigator who also works 10 hours with our program a week. So from that, my interest in the culture and learning more about their health beliefs, etc., took place. So through my faculty position at the College of New Jersey, I was able to work with our Center for Global Engagement And in January 2020, pre-COVID, traveled over to southern India because of a partnership we have with what is called Prevera Medical Institute. It's a very large organization that includes a hospital, a school of nursing, a school of medicine, a school of social medicine, etc. And they also have outreach to their rural and tribal community. So I went over there and I was asked with some other representatives to participate first in a colloquium. And I was able to talk about our program at MD Anderson Cooper, share a little bit about the screening program. And also they wanted to hear about advances in chemotherapy and palliative care. So I presented all three of those programs and developed a relationship with their medical director for their laboratory setting and medical oncology, with their school of nursing, with their director of social medicine, and actually met with the pro-chancellor of the university and have an ongoing relationship with them. So to date, I've been able to share educational resources and have continued in conversation with them, but they are very interested in setting up a cancer screening program specifically in their rural and tribal communities. The tribal community has a beautiful health center, which has a physician that has worked at it for over 15 years. The women basically walk there by foot and are seen for all kinds of medical conditions. And they also have a very strong women's health program there. Of course, they're, have an ambulance that can transport to the hospital if needed, but a lot of the care occurs in that tribal center because it is about a 3-hour drive from the actual hospital. So I would like to, as soon as the restrictions for COVID is lifted, to return there and continue our partnership and do some training with the nursing staff and the individuals at the tribal center related to cancer screening. And hopefully by next January, possibly go and visit again and bring some of our advanced practice nurse practitioner students from the College of New Jersey or any of my peers with me to try to do some education and some screening on site. So
that's really true.
Any questions, I can answer them, but I would really like to speak with my colleagues there in Texas and find out about, the programs that they're doing and just ask some questions, etc.
Great. Thank you so much, Sharon, for sharing that with us and letting us know. If you wouldn't mind just putting your email in the chat again. I think there are several of us that would be interested in potentially collaborating with you and certainly helping in any way we can. As you heard from Stella and Kathy, we also have a very active, a lot of interest from our nursing colleagues as well in global health, in addition to our all our trainees and faculty as well.
I'm putting that in now.
Does anyone have any questions for Sharon? Great, thanks, Sharon. To switch gears a little bit, one of the challenges we've encountered in doing a lot of this work has been, especially when it falls under the research category, is the ability to share data between institutions, which is obviously becoming harder and harder. We're very lucky to have Joe Thomas with us today, who is one of our software engineers and who runs our REDCap program. I don't know, Joe, if you can just say a couple of words about your experience in helping all of us with global health projects.
Yeah, sure. Can everyone hear me? Well,
yes.
Okay, great. Yeah. So thanks, Kathleen. Yeah. So I think we first started in, I believe I met Kathleen in the early maybe 2014, 2015. And the project was, we've got people on the ground in Brazil and other places, and we've got to be able to share data and sort of kind of mentor them in data collection best practices and how to do analysis. So we came up with the solution called REDCap, which again is NIH funded, and it's actually free for any PI, anybody that's doing nonprofit, medical related research. It's actually free. So it turned out to be a great solution. One, because no one had to pay for any high cost licensing fee. Two, because of its international nature, a lot of people knew about REDCap and have used it in other countries, especially Europe and Latin America. And because it was routable from the internet, which means that anybody can reach to it, just like Google or Microsoft or any other website, it allowed for ease of use, and actually people could actually play around with it without having to go through the onerous process of having an account with MD Anderson. They could just kind of identify the PI, give their email, and be allowed to enter into the specific project. So that barrier to entry was really, there wasn't much of a barrier to entry, and people really got a chance to actually enter data very easily, which then allowed our PIs here to kind of collect and analyze and get together easily and be able to kind of make some publications out of it. So we're still ongoing recently with we have 2 projects in Mozambique. We will do one and Rice is also coming on board for another project recently. I was there. So overall, it's been good. And it's kind of like ECHO. We kind of provide some professional services. And after a while, people pretty much gravitate to it, know what to do with it, and become really proficient in it. And recently, last week, we just had the 2nd annual Latin American REDCap conference in Brazil. It was obviously virtual. And one of our partners actually presented their solution for what they did. And everyone was really like, wow, I didn't realize that El Salvador, this is where this company was, actually managed to do a project. And they themselves are also doing projects with Haiti and other places. So what started out as a relationship in like 2015, 2016, they've kind of taken it and run with it. So it's good to see other people endorsing that. So that's great.
Thank you, Joe.
Sure.
Any questions for Joseph?
I have a question. This is Chidinma, one of the Radonc residents. Can you hear me okay?
Yeah, I can.
Okay. Hey, Joe. You mentioned earlier how MD Anderson started using REDCap. I think I missed a little bit of that, but you mentioned that it was free for like academic research or nonprofit stuff. And I was wondering, how do outside institutions get access to REDCap, like beyond us kind of inviting them to be users on some projects that we create, like in terms of an institution in Nigeria, for example, wanting to build out their research capacity more independently, how would they go about doing that, and would it be at cost?
Yeah, so there's a very straightforward process. You become part of what's called the REDCap consortium. That's who we are. And what they ask is, so for that institution, someone representing legally that institution would say, yes, we are a nonprofit. We will not sell REDCap services. And once they agree to that, then basically they're given the software for free. And if they want to, they can actually, instead of going and buying machines to put this software on, just like our desktops with Excel or something like that, they can actually rent space. So the cost would be maybe on AWS or Azure. These are cloud-based systems. You could take the REDCap that's free and then put it on Azure or Google or AWS, which is Amazon, and run it there. And of course, those places charge you maybe dollars a month or something like that if you don't have the hardware. Now, if you're willing to buy a machine and that can support REDCap, then by all means in Nigeria, perhaps you go to a computer store, you pick up a server, but the software is free. Once you sign this agreement that you're going to play by the rules of just a standard, we're all in it together. We're trying to do research in a non-profit oriented way, so to speak. You then will be, it takes about a week, and then you're given the right to go and download the software and then put it wherever you want.
Okay,
So
but you would need to have some kind of IT infrastructure, someone who's familiar with like working with servers and putting things on AWS or
right.
whatever,
So
server, online server.
Yes. Yeah, so you typically do, but we have, so like in the case of El Salvador, they went with Azure, which is a Microsoft cloud-based provider, and they kind of read the documentation and they were able, but they hit some snags, and so they called us, and we were able to help them for a couple of hours and got it up and running. So I don't want any, and this is the key, I don't want people to think they're left alone wandering in an open ocean without anyone to call. So I think we kind of make it comfortable enough to reach out to our team. And since we're part of, global health, we're more than happy to take some time to kind of make sure that if they needed their own REDCap, we're more than happy to help them out with it.
Okay, that's very helpful. Thank you so much.
Sure.
And I'll say just from the clinical side that we started collaborating with Joe and their team for really our specific research projects, and it's just been amazing what they've done. I mean, the El Salvador example is really a good one, as well as Brazil, because essentially these institutions said, wow, this works really well for our project with you, but what can we do with all our own projects that don't involve you? So I think it also has really helped raise the bar on data security for some of these other institutions as well related to research. So, and Joe and his team have really spent hours helping lots of different groups, and pre-COVID traveled with us extensively to help set these up. They actually had a specific grant through the Sister Institution Network at MD Anderson to do just this. So kudos to Joe and Mark Mansell, who also works with them, for really helping to set this up to make it possible for us to do research in our global oncology, associated with our different global oncology projects. Other questions or comments? There's a question in the box, or in the chat, sorry. A question for our trainees. What are some of the things you look forward to learning in terms of new skills and knowledge through collaborations with colleagues in LMICs? Dinmar or Dasha or Allison?
I can, this is Allie Martin, and I'm happy to defer to any of my colleagues, but I mean, I think it's endless. Like, for example, when I was doing my Fogarty year in Rwanda, there were so many unexpected moments of collaboration, even when it came to submitting an IRB, just understanding how to navigate that process. And sorry, my light is acting funny. Navigating that process with the assistance of somebody who understands all of the different nuances, whether they be cultural or procedural, and just how disease processes present differently in different settings, and what the influencing factors are on differential disease presentation. That's one of the most fascinating aspects of what I've learned through global work. So, all of that is so fascinating to me.
Yeah, I'll kind of add that. So one thing that I am kind of looking forward to learning more about is how are things on the ground? Because it's so easy to collaborate remotely and design research projects, build databases, and have someone on the ground help to collect your data. But then, when you actually travel and go on site, you become so surprised about what the conditions are and what limitations they face with doing research, whether that be like lack of constant power or something basic like at MD Anderson, we know that we have Wi-Fi throughout the entire hospital. They don't necessarily have that. And so like thinking about how you can better support your research collaborations abroad, like Joe was mentioning with REDCap, it's such an amazing tool. You can collect data remotely without internet on your cell phone and then go and upload that to REDCap once you do get access to Wi-Fi. So I'm super interested in learning more about some of the on the ground issues and how to kind of like address them and brainstorm and thinking about things that you don't necessarily think about when you're not there.
Hi, everyone, and this is Asha. And I want to echo to Digma that by being on the ground in a country, I think there's so much I have learned about healthcare systems that are different, about how you can organize care without presence of specialists. For example, I've talked about how there's an insufficient number of medical oncologists to deliver chemotherapy. But for example, in the HIV epidemic, there are not enough infectious disease specialists, and we see clinicians who would be the equivalent of our probably nurse practitioners or PAs be able to administer HIV medications by protocol, and some countries are doing that for chemotherapy as well. So thinking about, with limited resources, how do we still deliver good care? And also thinking about, how frequently do we need to monitor patients? How do we make care more convenient for patients who are rural? And I think telemedicine has, especially in the setting of COVID, has offered us some ways to do that. So to see what are some innovations that we can implement. And then one of the other things I'm really interested in is actually program evaluation and what we can learn from really talking to people on the ground who are taking care of patients. And that could be clinicians, social workers, the local PIs who are running research projects. Because what I found is if you talk to multiple people together, you often find things that you do not expect to find, and you find unexpected solutions. So you could find like a low cost way to maybe tweak shortages of chemotherapy drugs, or low-cost ways to improve follow-ups in your patients who are previously lost to follow-up. Or you can find that you implemented a program that is kind of well-meaning and you really tried to include the community, but you found that the people that you recruited to be your peer educators really feel that they have not been sufficiently included or well compensated, and then you're trying to make your program more just and equitable and to empower the people on the ground. So I think there are just lots of things that are surprising, and I'm always learning from working with partners. So that I'm just looking to more of that.
And there's a question regarding cost of sub-Saharan African healthcare providers training. If you want to join, how can those costs be supported? So we do have some funds that we have used to provide grants to our faculty who are leading some of these training efforts. Dr. Jingran can speak more about the training in Zambia. And what we are able to support is travel for the trainees to travel to Zambia, and the curriculum and all of the materials are already provided as part of this program. Dr. Jingran, would you like to elaborate on how anyone can join the training?
For Susan, maybe?
Actually, Susan's still here with us. Susan, would you like to comment?
Hello, sorry, I didn't get the question.
There's a question about how can someone participate in the clinical oncology training in Zambia if they want to join as a trainee.
Okay, great. I'll send on the chat box, I'll send my email and they can get in touch with me through email.
Wonderful.
And then
I would like to, go ahead.
No, go ahead, Shubhra.
Actually, I was going to ask Dr. Burns to speak a little bit about her experience regarding continuing the momentum of initial interactions with international collaborators. She described a very nice program that she's working on with colleagues in India. Dr. Byrne, yes, thank you.
Yes, that's right. So what specifically, I'm sorry, what specifically would you like to me to talk about?
We have seen that it takes a while to develop the trust and a format that works in supporting the training and all educational activities that are conducted in person and on site. It's very easy to lose the gains that you make in a visit through a workshop or any specific activity to be carried forward and translated into actual clinical practice. So are you, do you have a form of communication that has been developed to continue the momentum that is built with initial interactions? So how do you make sure the team at the other end is, they continue the motivation and they actually bring into practice the things that they learn from you?
Okay. So I'll address it from the two aspects. So as far as the dedicated clinic that we run here in the US, specifically targeted to the Asian Indio population, I will acknowledge that that started out very slow. So when we first started it, we needed to go to the population and started it with providing educational programs at their actual temples or some type of community center. And an outreach, our outreach worker, Eugenie, actually went with one of our providers and did an educational session and told them about the screening that was available. And the providers did two things. We introduced ourselves and basically told them that if they did sign up for the screening and came to the outpatient clinic, that they would see us. And we are one of two female nurse practitioners, because that population of the women did not want to see a male provider for their initial screening visits. They were very hesitant. So we started out probably with maybe 3 or 4 women signing up for the screening, and a few of those did come with their husbands because they did not have the trust in that program, and thought that somehow, even though this screening was going to be provided free of charge through New Jersey Seed, that they were going to be billed for it. So once they started to come, and they met either myself or one of the other nurse practitioner, and we developed a relationship slowly with them. And Eugenie was also there as someone from their community as a lay navigator. They did begin to trust us, and through their own word of mouth with other people within their community, let them know about the program. So we started out slowly with doing the breast cancer screening, and we did do that on site at their facilities. And of course, we wanted to bring them in for the other screenings. And we also told them that, you know, if they were going to have a screening mammogram or anything else, that we would schedule everything on at the same time. So they could go from seeing the provider with the examination right down to radiology for a screening mammogram. And then anything that might need follow-up, Eugenie as our lay navigator would continue with them. So we went from these clinics as being probably, you know, 3 to 4 participants to now being a full day, and being able to follow up with most of them on a yearly basis, depending on what type of screening they needed. As far as the connection in India, I personally have been able to travel there twice. And in speaking with the patients that I do have here in the US, that basically was another kind of a connection for me as a provider, because we could speak about, you know, not only different areas in India, but also I got to experience firsthand their beliefs and their hesitation with medicine here, you know, within the United States. As far as the program,
Sharon, I apologize for cutting you off, and I'm just worried that the session's just going to cut out because we're over the time.
Okay.
So, but I apologize. We really appreciate that, and I think we'll be in touch offline as well.
Sure, and anybody can email me with questions.
Great. Thank you so much, and thanks for joining. So I just wanted to thank all our speakers for joining today, and all the participants. And I especially want to thank Shubhra Ghosh and Melissa Varone for organizing everything for us and for all the speakers. So thank you all for joining, and hopefully we can continue these conversations. Have a good day, everyone, and enjoy the rest of the CUGH conference.
Thank you, everyone.